We have a panel of experts to help your family make end-of-life decisions and answer your questions about hospice care solutions. That's our topic as we're set to go live with Call the Doctor right now.
Call the Doctor, WVIA's award-winning healthcare program. Moderated by George Thomas. Call the Doctor.
Hello and welcome to Call the Doctor, live from your public media studios. I'm Joe Chrobak. The concept of hospice is centuries old and came from the idea of offering a place of shelter and rest to weary and sick travelers on a long journey. There are so many issues and decisions to be made as the health of a loved one deteriorates. There are many issues you and your family may face when determining whether to put them into hospice care or not. Tonight, we've gathered a panel of experts to answer your questions and tell some of the solutions available when making these big decisions. We will talk about hospice care and explain palliative care, which is the treatment that enhances comfort and improves the quality of life during the last phase of life. While the death of a loved one is difficult, there is a lot to learn about hospice care and how to make the transition easier on the patient and the family. Please join in with your comments, questions, or hospice-related stories by calling the number on the bottom of your screen. You can also send us an email by going to WVIA.org and click on the Submit Questions button. We've assembled regional experts and they are ready to answer your questions about hospice care solutions. Our first guest is Dr. Vincent J. Vanston, a fellow of the American Academy of Hospice and Palliative Medicine. He serves as the Clinical Associate Professor of Medicine at the Commonwealth Medical College. Our next guest is Dr. Alex Nesbitt, the Medical Director of Susquehanna Hospice and Palliative Care. Also joining us is Dr. Mary Catherine Cruciani, who practices internal medicine and is the Medical Director of Geisinger Home Care and Hospice for the Geisinger Health System. What makes Call the Doctor so very unique is the ability for you to interact live with our region's finest experts for an hour as we go beyond the trendy news soundbite and offer real information and help for you and your family. So we're going to open up our toll-free lines right now and give you the opportunity to ask your questions about hospice care solutions and share your stories of how hospice care has affected your life. Thank you all for coming today. I know this is a really, a difficult topic for many, and I said that in the open that nobody wants to talk about death, and maybe people don't know that their options as their family starts to reach that age and become sickly, but hospice is now very common in the medical profession, and I think we need to start with a little basis of what is hospice care? I mean, what is it to someone who's never heard of it? I read a statistic where 83% of Americans didn't even know what hospice care was, and that's an astronomical amount to me, especially with such a needed service at such an important moment in someone's life. And I'd like to start with you, Dr. Vanston. Can you kind of break it down for layman's terms for a little bit less? What's hospice care?
I think hospice care is a system of care which focuses on relieving the physical, psychological, spiritual suffering of patients near the end of life or who are dying of a terminal disease. And towards that end, it's an interdisciplinary service. It requires not only physicians, but nurses, social workers, pastoral counselors, aides, volunteers, and the like. So it really is a team effort of care. And I think of it really as good medical care for patients who are dying.
Well, I mean, that sets up a lot, and then we're going to get into this, not so much in depth with medical terminology, but we will have to cover a little bit of that as we get through this. So we're going to talk to Mary and Dr. Cruciani and ask you something about, he explained hospice and what it does for a patient, but what determines when a patient is ready for hospice? I mean, when do you make that decision?
The decision can be made by the patient themselves or family. They can approach their primary care physician, or if they're in a facility like a hospital, the physicians taking care of them in the hospital may approach the patient and the family and tell them that there is no longer a curative treatment. And I think that that's one of the issues that people have to understand, that hospice is not that there is no treatment. Okay, we are progressing from curative treatment to treatment of symptoms. So when there is treatment of symptoms, then the hospice organization can be contacted, and if the terminal illness is felt to be such that their life expectancy would be less than 6 months, certified by 2 different physicians, then they would be enrolled in hospice. Now, the patient has to agree to this. They have to certify and enroll. In patients older than 65 or eligible for Medicare, they have to be eligible for the Medicare Part A benefit, and whatever, again, if they're under Medicare, whatever hospice organization that they enroll with has to be certified by Medicare as well.
Interesting. So Medicare does help to pay for some of this, because it's got to be very costly. We won't go into the numbers, but it doesn't seem like with all the people that Dr. Vanston had mentioned, that with all those people helping, even volunteers, so we'll get more into that, but it has to be something that's costly to the to people, and I don't think it's something you want to have to end up paying for years after. So
well, and it could be frightening to the individual patient and family if they you know, had to absorb this cost themselves. So basically they give up the Part B of Medicare, and all the care is given under the Part A of Medicare.
Okay. I mean, you don't want to have to, you know, make that decision based upon the financial end of it, you know, whether to go to hospice or not to go to hospice.
Exactly.
So I guess that's a good reason.
But there's the terminal illness certification by 2 different physicians as well.
So 2 doctors have to come up with the same diagnosis as to
right. To
the
certify
term of life, right?
Right, right.
Okay, we're going to get into this, but as we mentioned in the open, we talked about palliative palliative care being part of that. I'd like to come to you and ask a little bit about what is the difference between hospice care, which we discussed, and palliative care?
So hospice care is for patients who are terminally ill, who are likely to die within 6 months. And it is really helpful for the patient, for the family. For people who are sick, but not necessarily dying, not necessarily terminally ill, but dealing with some sort of illness, chronic lung disease, heart disease, different issues, they really have a lot of needs for help, controlling their symptoms, helping to make hard decisions. And palliative care is a team of people who work to do that. So palliative care is like hospice in that it is a interdisciplinary team, a doctor, a nurse, chaplain, social worker, different people coming around the individual and their loved ones to help get through this difficult time. But it's unlike hospice in that for palliative care, you can be years from your dying time. If you're just having sickness or problems and you need help, palliative care can help you. And for hospice, for someone to enroll in hospice, they generally need to have said, you know, I'm not pursuing aggressive curative treatments. There's no other curative treatment for my cancer or whatever. For palliative care, it's not like that at all. So you can have palliative care in the midst of your aggressive chemo treatment or radiation or in the ICU or wherever you are. So palliative care is directed to a much larger group of people. Hospice is focused on those people who are nearer the end.
I agree with Dr. Nesbitt that palliative care can run concurrent with curative treatment, and along those lines that he spoke of symptom management and also helping families and patients to make hard decisions about the future of their care and what their goals are.
I imagine you guys have to spend hours talking to patients and kind of letting them know their options. I mean, at that moment, it has to be very overwhelming to them to know that a loved one is reaching term of some extent, and they have to make a decision, and it's got to be very difficult for them to process all that information and to discuss things of palliative care or hospice care, you know, to make those, what's the word, those hard decisions to come up with, and it's got to be very difficult. We are going to talk a lot more about the solutions. I want to go to an email that came in. It was something similar that I was going to ask actually as well. What are the benefits of hospice care versus home health care? I mean, I think in this discussing solutions, we're going to have to get into a lot of the different solution options. What options are there for hospice care? I mean, is home health care part of that? Is there one of the new, maybe you can answer that, Dr.
Well, there is a transition. Some people, home care, in some home care or agencies, they do have a transitional care where patients may be receiving, for example, radiation, palliative radiation therapy, and then would go on to hospice care. The team approach is available in hospice care, which is not usually available in home care. There is not social workers available, pastoral care available. Home care does have aides, but hospice care also, again, with Medicare in general, will supply the durable medical equipment, which home care does not. It will also pay for any medications that are appropriate to the diagnosis for which they are entered into hospice. So there are certainly advantages to hospice care versus home care in a terminal illness. Okay.
Dr. Vance?
I think the other thing I would add to that is that hospice home health care will often be for X number of visits. We can see you for 5 times for a particular problem, whereas hospice care will provide continuity of care as much as they need it. Okay. And they will stay with you during the course of the illness, you know, until you die.
So in the benefit of the patient, it's probably better for them to be in hospice care if they're at an extreme level?
I think so, yeah. I think it gives a lot more continuity, it gives a lot more support to the family, it gives consistency. I think consistency was the word that I was trying to find.
Okay. Well, you know, bringing that up, that's a good question to me. Is all hospice care the same? I mean, if we go to one hospice facility versus another, do they all come in the same fashion? I mean, if I'm trying to pick a hospice facility, does everyone, we talked about the number of people, even in palliative care, you talked about the number of people that are there to help. Is every facility the same? Is it like hospitals? Are there some differences between, you know, wings in a hospital, you know?
So there are a couple things. Number one is hospice. Most hospice care is done in patients' homes, whether it's their own home or if somebody is living in a nursing home. So most of the time, most hospice is not a facility that you would go to, but hospice coming to your home to help give you care there. There are some hospices, for example, in my hospice, Susquehanna, we do have a facility, an inpatient hospice unit that's a part of the care that we give, but it's only a small care. Only a small number of people need to come into our facility and get the intensive hospice treatments that we're doing there. Most people want to be home. And different hospices, I do think there are differences. Some hospices are bigger, some are smaller, some may provide more services, some a little bit less. So I think it's quite appropriate to be asking if somebody's thinking about which hospice they want to join in, what sort of services are available and that sort of thing.
Well, maybe I should back up and ask a different question. I have a mother, she's aging. I can't say her age because she won't let me say it's over 30, so I'll just leave that out, Mom. But my question is, at some point, do I want to ask my mother what would be her you know, thoughts or ideas when this question comes up? I mean, it's not something you want to talk about at the dinner table, you know, every Sunday, but maybe it's something that you should bring up. And what's maybe the point if you guys have an idea of that? When do you ask that question?
I think one of the biggest problems, and I worked in a palliative medicine consult service for many years in the hospital and outside the hospital, and I would be curious what the other panel members said, but I think one of the biggest problems I've seen is that people do not communicate or talk about these issues. That your grandmother or your mother will have many serious illnesses, and yet we never talk about the possibility of when things go bad, how are we going to deal with it? And most of the distress I've seen both in patients and in family members is when those conversations don't happen. Is that so when family members take the time to have a discussion about what their mother or fathers or relatives or spouse, you know, what their goals are, should things not go their way, what would be important to them, what kind of things they should focus on, what kind of care they want to have. That is worth its weight in gold to have those conversations because it relieves so much distress in the family and family members.
Dr. Nesbitt?
I would really agree with that. What we're talking about is called advanced care planning. And advanced care planning is the kind of talking with our loved ones, the people who would be around our bed if we're really sick, who will need to know what sort of decisions would honor what I would choose. And the most important pieces of that are, number one, if I get so sick that I can't say what I want to have done, who do I want to speak for me? In the state of Pennsylvania, that person is called my agent. And it's really important for each of us to think about who would I want to speak for me, and then to talk to that person and let them know how you feel. If you're going to be my agent, I want you to know that if I can't do this, I don't want machines to keep me going. So thinking of who would be my agent, naming them, talking to them, writing that down, really important, because in real life, every day in the hospital, doctors are struggling to make sure we do the right thing. And often by the time the person is that sick, they're not able to sit up in bed and say, here's what I want you to do. So we're trying to do decisions that honor them. We turn to the families. Even if a family really loves them, often they don't know exactly what dad would want. So talking about that sort of thing is really, really important. And then the other thing that's really important is what sort of living is okay with me. If I am like this, then I wouldn't want to have interventions that would keep me like that. Everybody's line is different. For some people, as long as they're breathing, they'll take every darn machine to keep them going. Most people have some other point that they would say, if I can't be awake and look at my wife or communicate or maybe get up, everybody has a different level, but it's really important for your loved ones to know what is okay for you. And very often this has not been talked about, so families struggle to do what is right.
Often you will hear, if someone comes into the hospital, they will ask who is the durable power of attorney, which means who is the person that is going to make decisions for this patient if they cannot make decisions for themselves. So just knowing that term, durable power of attorney, is also one that is agent. In addition to, when you asked, well, when would you speak to your parents about end-of-life issues? Take time when everyone has had family members that have passed away, elderly family members. Take those particular times to talk about these issues. You have to look for, as a younger person, you have to look for opportunities to open the conversation, because it's not an easy conversation to have.
No, it can't be very easy. I know it's in families it's tight-knit about certain things in general to talk about, but nobody wants to ever talk about death or bridge that gap of communication. Do you approach your family members first to pick an agent? Do you discuss it with the elderly person in the family first? Where would you go with that?
I think the important thing is just to have the conversation with the individual if possible. Open forum. And oftentimes it's not as difficult as people think.
We all know it's coming, Dr.
Right,
Van.
But it really isn't as difficult as thing. Oftentimes you say, mom or dad or brother, I'm concerned about your health, and it's important to me to do the right thing by you. Should you be in a situation where you're not able to speak for yourself, and I want to make sure that we're providing the best care we can, for you. And I think opening up those conversations. And the other thing I found over the years is that people are relieved to have the conversation. Because if you think that, a doctor who I spoke to once, he said, someone who has cancer, you think they're not thinking about dying? Or people who have advanced disease, you think that doesn't enter their head? Yeah. And so there's this elephant in the room that nobody wants to speak about, and when you actually do start to have the conversation, a lot can happen.
I was going to ask, does it relieve some of the, I'm sure depression comes with the whole hospice term in general. Does that relieve some of the family strain when somebody does hit that point? Is it better to have talked about it before it occurs? You know what I mean?
I think it's better to have talked about it way before it occurs. So this sort of advanced care planning, someday, eventually, when I get so sick I can't decide who do I want to decide, what sorts of things are important to me. It's really important for that to have happened way before the hospice discussion. Often in our world it doesn't. People don't think about these things until all of a sudden they're sick enough to be talking about dying. But this sort of thing is really important. It's this core human connection we have with people that we love. And I think what Jay said is absolutely true. When this conversation comes up and you talk about, I know you're okay, Dad, but someday, if you got really sick, I want to make sure I do the right thing. I love you. And what sorts of things would be right? What wouldn't you want? Once that conversation happens, Dad usually feels good. I'm glad we had this talk. And the son feels good. It's this core connection that even people who are nervous to go to a lawyer and fill out some formal paperwork, I don't want to do that, they do like talking to people they love, and they do like talking about ways to honor and care for each other. That's sort of common across human experience.
Well, I'm hoping we maybe have instigated some phone calls where moms and dads are calling their kids and saying, hey, I'm watching this great show and I wanted to bring up some great topics, so maybe we can at least get people to talk about it. And at the very least, we're giving them information, but let's see if they can tell their family about it. I would like to go to the phones now and talk to Joni from Wilkes-Barre and invite Joni into the conversation. Joni?
Hi. What I was calling about is I have horrible pain all the time, chronic pain. I've had it for 11 years, and the pain is horrific when I sleep or when I'm tired. I'd like to know if there's something like palliative care that I could go to get my pain under control.
I think Joni's asking more about medicine dosage given to her. But
And Joni, I heard you ask about palliative care, if there's palliative care or something like that to help you with your pain, is that right?
Yes, because I'm like a cancer patient, but I don't have cancer.
Right, so palliative care is a relatively new specialty in this country over the last 10 years. And there are some communities where there is a well-developed palliative care system, where there are palliative care clinics that you can go to and palliative care physicians. In some communities, there's not such a well-developed palliative care system, not yet. So it probably would be right if you talk to your private physician, your family doctor, and see what sort of resources they know to help you for this.
I hope you answered Joni's question. We have an anonymous caller from Honesdale. I'd like to invite them into the conversation. Go ahead. Are you with me?
Hello?
Hello. Go ahead and you could ask your question.
Yeah, I wanted to know, my father died less than a month ago. Can you hear me?
I can. Go ahead. I can hear you.
I had hospice called in.
Okay.
I called hospice in. I wanted to take my father home from the hospital.
Take your time, honey.
And I couldn't understand why hospice didn't offer more home health like in the aids. They told me that the most maybe an hour a day.
So in general, I'm sorry to hear about your loss. It sounds like this was a terribly hard situation. I will tell you that hospice really works to try and provide the care that you need and works to match the services from the hospice team with what you need. It is true there are limits to that. For example, a hospice can't have an aide come and stay there 8 hours per day or something, but usually if there's someone at home who is needing more help, hospice will work to float more help, daily nurse visits if need be, aid there as much as can possibly be done to help with what needs to be done. So,
I think for the general public also, I mean, it's important to speak with the hospice program that you're using and ask them what kind of services they have available and what kind of support they can give. Oftentimes the care changes with the demands of the patient and the family. Many hospice programs should have the capacity to provide continuous care for short, brief spurts of time. If there's really a crisis at home that they can manage over 24 hours, and they should be able to gear up if that's necessary. But as Dr. Nesbitt said, the services need to meet the needs of the patient and family and should be adjusted to that need.
I'm sorry about her loss as well, and I'm assuming the grieving process is something that you guys do have to talk about, and I'm sure, hopefully she's working with someone to get through this loss. But do you guys have to work with that? Is that part of hospice care? Does grieving come at the end of this process? Do you have to deal with the families? I mean, you can't just let them walk out the door. You have to know that they have hit a rock or a hard point. Does it come as part of not your services, but as a lending ear to being there for them?
Well, actually, it is a service of the hospice program to provide support to the family, and I believe it's almost up to 6 months afterwards, as I recall. Up to a year.
Yeah.
Up to a year?
So the services are provided by the hospice program.
And that's part of the pastoral care, or it can be part of the volunteers as well, who will contact the family members and see how things are doing. And many times there's a memorial service once a year to commemorate everyone that's been part of the hospice in the prior year. So,
I think that's right, and I think thinking about grief and loss, that's something that happens before the individual has died. So the person themselves, as they're coming to the end of their life, often are grieving losses. I can't get out and do the things I used to do, or I won't be able to accomplish those things that I wanted to. And the families thinking about the loss along the way. And then after the person has died that they love so much, the grief persists. And it's quite right that that's an integral part of what hospice does. For 13 months after the death, there's bereavement services that are a routine part of what hospice does. So cards and memorial services and groups where people who have lost loved ones can get together and share with other people who are going through this terribly hard time. Child bereavement programs. In our hospice, we have a program for kids who have lost someone they love very much, because kids grieve in a whole different way than adults do, and young kids grieve differently than older kids. So having groups that are designated for different age kids so they can be with others their age and process this as they do. Really important help.
Well, you brought up the topic of age, so I guess we'll go into that. I mean, death occurs at any age. It does not have a particular number that it doesn't find to be part of its numbers, unfortunately. I'm assuming pediatric palliative care or pediatric hospice care is part of this as a separate, I don't want to say separate service, but a different kind of a portion. I wouldn't think they get the same treatment as somebody who's in their 80s and aging, you know, what we would expect to be a long, healthy life. I mean, we're talking children in their youth who are stricken with cancer or some other non-curative disease. Do we do something special for the children? How do we address that?
I guess I'll start with it. Thank God we don't have to have a huge need for pediatric palliative care and pediatric hospice. That's the way I look at it. But it's a very difficult field, obviously, as you can understand. One of the challenges in this region in northeastern Pennsylvania, and I'm not sure if in Williamsburg, is to start developing the infrastructure to provide that kind of support. Because, as Dr. Nesbitt alluded to, you know, the care of pediatric patients or children who are dying has a whole different set of dynamics around it. And that I think we need to develop the infrastructure and support services in this region to provide the care. That's my sense of it. Sure.
Right.
Agreed?
Okay. That's right. And pediatric hospice for children who are dying, or pediatric palliative care for children who may be really sick or dealing with hard problems but not dying. It is true that in some areas it's really well developed. In our area, still growing and developing, I think, all across our region.
I mean, there's going to be changes, I guess, as we go along.
Yes.
Well, I think it's
Absolutely.
also a reflection of the population that we have in this area. That, you know, it may be more developed in the greater DC area where the population is younger than in our area.
We do have a large elderly population here. It's a statistic we don't avoid in topic because it's true. I'm going to ask, does that require more hospice facilities to be available with the larger population? Would this be a hub of activity?
I think that northeastern Pennsylvania is kind of at the vanguard of the challenges that the rest of the country is going to be facing in the next 10 years. That we have a very elderly population and all the problems that come along with that. And so not only do we have to expand and solidify the hospice support in the area, but also to develop palliative care services to meet the needs of these patients and other services that need to meet the needs of the elderly. You know, when people think of hospice care, they only think of cancer care, but really, it is not only cancer care, but patients with advanced heart, lung, liver disease. But a large proportion of patients, probably more than any of the others, is this idea of kind of progressive frailty. And so we don't have a system in place to take care of the 85-year-old gentleman who has some vision loss and hearing loss and weak, you know, broken hip and a little bit of dementia and heart disease and kidney disease. And so we need to develop those kind of service in the area. So it's a real challenge. But as one of the blocks, I think developing palliative care and hospice care is critical.
Well, I know they say that the elderly homes will be overburdened at some point because there's just too many people going into nursing homes, and they won't be able to, you know, withstand that number. And
the system
I imagine it's got to happen just the same. And not everybody has an easy bout of aging. No. So I imagine that palliative care and hospice care has to be a large proportion of that, where those people need those facilities to take, you know, the services and help them. You know what I mean? It has to be part of that.
The other thing I would point out is the biggest demographic challenge is the baby boomers, our generation, which is this enormous swell of people who are increasingly moving into the age where there are more and more health challenges. And so the need to have really growing palliative care services and hospice services for an increasing number of people, it's just getting more and more as this swelling in our population comes along for that age group.
As a Generation X, it's nice to watch the baby boomers and how that's shifted and changed the world. I think it's as far as that, just between trends and health habits alone. And I think it's a weird thing to sit in the back seat and watch. It's hopefully that everybody grows old and we don't have to see people fade away as a way of looking at it. But it is nice to see them growing and setting new trends and changing the world. We're at the halfway point of the program, so I think maybe we'll do that, and then we'll take some more phone calls right after the break. For more information about hospice care solutions, you can contact the Commonwealth Medical College at the commonwealthmedical.com. You can get Susquehanna Health at susquehannahealth.org. You can contact Geisinger Health Systems at geisinger.org, or you can also go to the Geisinger Community Medical Center website in Scranton, geisinger.org, /GCMC. At this point, I'd like to reintroduce our panel members to you. Our first guest is Dr. Vincent J. Vanston, a fellow of the American Academy of Hospice and Palliative Medicine. He serves as the Clinical Associate Professor of Medicine at the Commonwealth Medical College here in Scranton. Our next guest is Dr. Alex Nesbitt. He's the Medical Director of Susquehanna Hospice and Palliative Care. And also joining us is Dr. Mary Catherine Cruciani, who practices internal medicine and is the Medical Director of Geisinger Home Care and Hospice Care for the Geisinger Health System. If you have any questions about hospice care solutions, or you just want to share your stories of how hospice care has affected your life, you can call us at the number at the bottom of your screen and you can join in this conversation that we're having here today. We do have some phone calls, and I think we'll take a couple more of those because it's nice to kind of hear the stories. I know they'll break our hearts a little bit, but again, we're here to be supportive of them. This is not something they're going through alone. As the number of people involved with hospice, you're not alone in this. It's a easing of life. It should be not so much a downward trend. Let's try to see what Linda from Jersey Shore is going to bring to the conversation. Linda, you with us?
Yes, I am.
Go ahead, Linda.
Okay. 1 year ago, my mother passed away at the Gatehouse in Williamsport, Pennsylvania. And I just wanted to mention that we were treated so very kindly. Dr. Nesbitt was wonderful with us and helped us through every step of the dying process. It made that as easy as it could possibly be for us losing our mother. And I just wanted to hear what we can do as the public to help to guarantee that the Gatehouse will remain available to people in our area.
Dr. Nesbitt, you're going to have to inform the viewers what the Gateway is for those who do not know.
Yes. Thank you. Linda, thank you so much. So the Gatehouse is our inpatient hospice unit. I said that most hospice care is done in the home. Our hospice at any given time is taking care of about 100 people in our community. But sometimes there is suffering or hard things going on so much that you can't take care of that at home. And so we have an inpatient hospice unit, which is a 7-bed unit in Williamsport, where we can do whatever it takes to control the symptoms that the individual is having. Terrible pain, terrible confusion, terrible shortness of breath, whatever it is that needs specially trained nurses there 24 hours a day, and a doctor, me, or my associate, just paying very close attention to make things the best they can. So that's what the Gatehouse is, and it's really been quite an honor to get to know families like Linda's family and many others in the hardest possible situation, where the people working at the Gatehouse come around to help. And I must say that there are people from the community who step in to help as well. So every patient who comes to the Gatehouse is covered by a quilt or an Afghan or something that's been made for them by people in the community who just bring these for a stranger that they've never met, just to kind of wrap them with some love. This is for you. People bring food so that families who are there will have something to eat. Musicians come and sing or play instruments for those who are there. There's just all different layers of the community coming around and helping strangers and families going through really difficult times. It's really been a very special thing. So people do give donations of all different types, whether it's financial or food or volunteer service. And those are the types of things that help so very much for us to do what we do there.
It sounds like a blessed place. I don't know if you guys are familiar with it or not, but it does sound, especially with the giving of the blanket, sounds like people are coming together to help be supportive of that. Linda, sorry about your loss. I'm sure that's been very difficult on you. Let's talk to Mary from Pocono Lake and invite her into the conversation. Mary?
Yes, I am.
Hi, Mary. Go ahead.
Hello. I wanted to ask, my husband and I are elderly, and we have a son living with us who's separated from his wife, and he's 48, and he has terminal liver and colon cancer. He lost his insurance from his business, and I wanted to know, how does it work if he's on medical assistance? Would we be able to get him into any place? I understand the cost that you people have must be horrendous, but is there anything for people who are indigent or just don't have money coming in?
That's a very good question, Mary.
So probably different hospices have different policies about it, but I will tell you that most hospices will provide care for whoever needs care.
That's true.
And whether it's patients that have medical assistance
So it
or
doesn't
no
matter.
insurance,
Right.
they'll do care, whatever is needed. It's a high goal for hospices.
So people shouldn't look at it as a financial comparison. There's a way to afford it by facility, no matter what facility you would find to be for that. That would fit you as a comfort.
Yeah, there's no situation where a person suffering from a terminal condition should not have hospice care.
Yes, that's right.
Okay. No, I mean, you're very right with that. Thank you, Mary, for your call. Let's talk to Jim in Clark Summit and see what Jim wants to talk to us. Jim?
Hello.
You there? Hi, Jim.
Hi, yeah, I have a family member who is terminal and who's very reluctant for hospice care. How do we convince him that he's ready for this care? He's fighting it all the way, and every time we bring it up, it's a fight. And any advice you could give me would be grateful help, very helpful.
One of the positive things is that the sooner that you are enrolled in hospice care, the more you reap the benefits. So enrolling in hospice care 1 week or 2 weeks before you pass away, you really don't reap the benefits. If you enroll further away from when you're going to pass away, first off, there's pain control, there's emotional control, there's the nurses and the pastor who can help guide your loved one through this. And if he is having pain, that nurse that comes to the house has the ear of his primary care doctor as well as the medical director. We have interdisciplinary teams once a week to go through how each patient is doing. So this may be a way, if things aren't going well for him at home, maybe he needs symptom control. Not every patient, what I would say to him is not every patient dies in 6 months. It's not a death sentence to be enrolled in hospice. And there are patients, particularly those that don't have cancer diagnoses, that will stabilize and may be discharged from hospice at certain times. So it is, that's a misconception that, you have to die within 6 months of...
They could also move over to palliative care, correct?
Exactly.
Yeah. The other thing, I think the conversation has to be more around what his goals are for the individual. It's very rare that I will walk into someone's room and say, you have to go to hospice care. What we'll do is spend a good, it doesn't take a lot of time, but take the time to talk about what are your goals, what are you looking for, what is most important to you. And oftentimes patients will say, gee, I don't want to go to the hospital. I'd like to stay at home. I would want, I don't want to be in pain. I don't want to be short of breath. I want support from my family. I need spiritual, guidance and the like. And at the end of that conversation, what I'll say to the patient is, you've just described hospice care. So why are you afraid of it? This is really what you're looking for. And I think sometimes if you go at it that way, it's really kind of establishing what their goals are. And what's most important to them, and then the answer drops out. You're not trying to force somebody. The gentleman is calling it sound like you're trying to convince them to use it, rather let the patient come to the conclusion themselves.
Well, we talked about the beginning stages of when to decide to go to hospice, and we talked about the end bereavement for the family. Let's try to help Jim out, though. Let's walk through what would happen if Jim finally gets his his loved one to come to terms that hospice might help. So he makes that decision, has the communicative conversation, he talks. What would Jim look forward to as the process would begin? So Jim finds a hospice facility. How easy is that? We talked about there's lots of them in the area, but does he look in the yellow pages? How does he get references to it? Is there online resources that he can say, this is more in line with me? We talked about there's different services between one facility and another. So where does Jim begin the process? Maybe he can...
Well, I can start it off, and then I think my colleagues can probably give more detail on what would happen in a home hospice setting. But I think to begin the process, first of all, is the oftentimes having a conversation with the primary care physician or oncologist, whoever is providing the bulk of your care. And oftentimes a referral can be made to a hospice program. Now, the truth is that there are many hospice programs, at least in northeastern Pennsylvania. And so oftentimes the primary care physician may recommend a particular hospice program, or you may do your own research, or you may have heard from other family members what's best. I think that begins the process. And once the hospice program is contacted, then they can make contact with the patient and their family to help determine what should happen next.
The other thing I would say is it's really important to know that if you get hospice involved and you choose a hospice, or often your primary doctor says, this is who I refer you to, and the hospice nurse comes to do the admission, sometimes people are afraid the nurse is going to come in and say, you're going to die, and be talking about dying and all that loss. Most of the time, no, the nurse comes in and is asking questions. What's most important for you? What do you like? How are you feeling? How can we help the best? And one thing that sometimes I think drives resistance to hospice is the fear that people are going to come in and tell you what you have to do or make you take certain medicines. Really important to know that you're still in charge. As the patient, the hospice comes in to follow your lead. If somebody says, I don't like medicine, I'll put up with a little pain, well, that's fine. I don't have to take medicine. They're in charge. Or I don't want you to come too often, just come once or twice a week. That's fine. We'll come as often as is helpful to you. So very often I find that people like Jim's father, who's initially reluctant, once the hospice nurse comes out, and she's pretty nice and she's helpful and she's not pushing them around, and they find, it's a darn good thing. I wish I would have had it before. So really important to know that hospice is not about death, dying, loss. It's how can we help you live every day until whenever your dying day comes. And the focus is not on the dying, the focus is on the living as well as you can.
And that's one of the differences between home care and hospice, which we discussed earlier. In general, in home care, the patient has to be homebound. They have a particular problem. They're not able to get to their primary physician or to a clinic, and so they have nurses going there. In hospice, the patient is does not have to be homebound. They can go wherever they please, do their activities of daily living. They don't have to be homebound. As far as goals go, I just want to relate that we've had several patients who actually have gotten married when they've been on hospice, that was one of their goals, and that they had not really addressed it. So it was a time with the team to address something that had been in the back of their minds. And that's, we help hospice patients to address some of the goals and desires that they've had. So.
If you want to make a story, if you want to tell us your story, or ask a question, you can call the number on the bottom of your screen. We're going to take an email that we got in here. So it's, how does having a relative in hospice care help grieving family members make that transition?
So I think there are many ways that it is really hard for the family of somebody who is terminally ill, is going through all the things that make that difficult. Physical suffering, your loved one is short of breath or having pain, I don't know what to do, I don't know what kind of medicine to do. Making decisions about, should we take them to the hospital, shouldn't we? Often hospice is an ongoing presence. Generally somebody will get to know their hospice nurse. And the hospice nurses are specially trained and particularly good. I must say I'm honored to work with the hospice nurses that I work with. And when families get to know them, they are an enormously important resource for the family and the patient with the day-to-day challenges that come up. So emotional, physical, spiritual, decisional, a shoulder to cry on, just somebody who's tapped into all of what you're going through. Hospice really is that.
Well, I think you also have, as Dr. Nesbitt said too, you have this network of support that's there that wasn't there before. You know, so people who are at home with a loved one who's dying or very, very ill, and they don't know where to turn to. And I think a hospice program can provide those elements necessary to see them through.
Well, let's talk about that. To go back to helping Jim out with his dad. So we've talked about how Jim has to have the communication. Jim did that. Jim's trying to talk to him, and Jim seems as though it's pushy to his dad, and he doesn't want to. I'm sure he wants his dad's best interest at heart. And then we said that he's going to get this network when he does go to hospice. What is that network like from a day-to-day? So Jim's father, I know you can't just walk in and check it out for a day, but if Jim's dad was to finally make that transition, to say, I'm going to try hospice care, see if it can help benefit me, so he goes there, what's the care he's going to receive? We talked about these nurses coming in and how they fit his mold. Is this 24 hours a day that he's going to have somebody that he can kind of talk to and say, I'm having pain? You know, how about the spiritual needs? If 2 a.m. a spiritual need comes up, when do these volunteers come to visit? Is this an around-the-clock kind of a thing?
Well, I think with the hospice program, part of the evaluation is determining what the goals and needs are of the patient and family. If you think about it by pieces, you know, there's going to be physical support, symptom support. So oftentimes a nurse can provide that physical assessment in communication with the primary care physician as well as the hospice medical director to provide, you know, to meet those needs. At the same time, people will have psychological issues, anxiety, depression, grief, and so there are counselors, pastoral care counselors, or social workers who can provide that support. Family members will often sometimes need help with insurance and how to get through the day and how to interact with other agencies and like in the community. So social workers can provide that support. Like I said, pastoral care, administrative and secretary support from the hospice program. So really when the patient is evaluated, all of those elements are brought together, and oftentimes that's done through an interdisciplinary team meeting where they will talk about a particular patient and say, okay, you know, have everyone around the table say what do they need and how can we best meet their goals.
The volunteers that come around, kindness of their heart, I'm guessing, to want to be around those people and help them out in that moment. Is there a way people can become volunteers? They just contact a hospice? I mean, is there too many volunteers? Is that a possibility?
Never too
Never
many.
too many, that's right. They have to go, the volunteers have to go through a training program. First off, there's confidentiality to be taught, but also how to approach a patient and family that are dealing with death and dying. A lot of the activities, sometimes they're just there to be an ear, okay, to let that person talk and not, you know, sometimes you get tired of talking to family members. They've heard all your stories. They want a new ear to listen to. Sometimes they run errands for the family. Sometimes, you know, if the daughter's a primary caregiver and she wants to go to the beauty shop, they can be there with the person who might need a little bit of support. So there's a lot. They also are, they help with our memorial service. Sometimes they help with phone calls in bereavement. There's a lot of different roles. They help with probably making your blankets, okay, or making different items. I think we have a teddy bear type of approach where every patient gets a teddy bear with an article of their clothing of their choice. So we've had people that have been in the military, might have part of the military uniform, and that teddy bear is given to a grandchild. So the volunteers help with the making of those.
Very good. We do get email questions, so we're going to go back to the email questions here. What are the differences between a nursing home and hospice care?
So hospice care is for terminally ill patients and is done in home, or hospice care can be done in the nursing home if the nursing home is now that individual's home. Nursing home care, most people in the nursing home are not necessarily dying. Many are there for rehab or other purposes. And it's really an entirely different kind of care than hospice. It's an institution, it's a place. Hospice is really sort of a philosophy and a type of care that comes in around the patient. So the two sometimes merge if hospice comes into the nursing home, but they're separate kinds of care.
I think one thing that is, in most cases, and I bring this back to Medicare, is that room and board is not paid for by Medicare in a nursing home, because sometimes there are misconceptions around hospice. Okay, and some of them are one that hospice cannot be provided in a nursing home. The other that I mentioned is that you have to die within 6 months. One of the other ones is that your primary care giver is not involved. These are all some of the misconceptions, and again, but you do need to know that room and board is not provided by the Medicare benefit.
When I think of nursing home, I think of that large percentage of people who did not get cancer, did not get heart or lung disease, or did not die of those things, and kind of develop this frailty of old age, or general frailty of old age. I think one of the things that hasn't been tapped in this region, which should be, is that nursing homes really should have strong palliative care programs in place that can recognize these patients who are frail and elderly, who are near the end of their life, transition them at the right time to hospice care, and really have a smooth continuity of service. Oftentimes we see patients in the nursing home are being kind of shipped to the hospital at the first sign of infection. Really, when that's not their goals, it's not what the hospital can really provide good services for. And so I think there's a huge need for that in the nursing
In
homes.
Williamsport, we've worked to that end, and we have a strong palliative care presence in our nursing homes. And boy, you are right. It's really important.
And I think that's where the rest of the regions need to move.
Well, I think that'll bring me to my question now. Changing trends. We talked about how in the early days or the inception of this, it came from people who were just helping out weary travelers. I mean, now we're taking and helping those that are weary in their transition to the next life or beyond. So what's the changing trends that are occurring as you guys have been in the field for a couple of days now? So what have you seen, or what's the future of this? Is there going to be some big changes? Will there be any new concepts applied?
So I think in hospice, there is growth across the hospice industry. More and more people who are terminally ill are benefiting from hospice, which is really helpful. It's really great. And palliative care, again, 10, 15 years ago, that just wasn't something that was a part of the American medical scene. Has been there for many other countries, palliative care for decades, but it's relatively new in this country. And palliative care in the hospital, palliative care in the nursing home, palliative care for people in the community like our earlier caller who needs help with her pain. So there's progressive growing of the palliative care help at all different levels where people need it. Palliative care for children. So there's just a bunch of changes across the whole system.
Anything else to add?
You know, we don't have the time to go into it as much detail, but I think that there are kind of trajectories of diseases that we've come to recognize, that people who have cancer have a certain trajectory to their disease and certain prognosis. Patients who have Alzheimer's, dementia, have a certain kind of course of their disease. Patients who have congestive heart failure and end-stage lung disease have different. We need to develop systems of care that meet the needs of those patients and their families. Right now we have a system that's based on one disease, and yet patients often have multiple diseases and multiple competing goals. And we need to develop a system that really kind of starts to recognize the reality of what we're facing and to provide the support. For example, for the patients, I think Williamsport's doing a fantastic job in developing palliative care for patients in nursing homes. That's what's needed, and that's what should be developed. We don't need more, I'm going to get in trouble, but we don't need more cardiologists, we don't need more caths, we don't need more ventilators. What we need is better services and service lines for these individuals.
And we need communication.
Yes.
There has to be communication with the primary physicians, with the nursing home, there may be nursing home physicians or directors, the families and the patients. And I think communication is the key to palliative care and hospice.
Right, I would say that's true. We're operating in a medical system that is very fragmented. If you go to that hospital and then you go to that nursing home and then you go to each is a different silo of care. And it's uncoordinated and it's inefficient. It's one of the challenges we face. Palliative care actually is a piece of the cure for that. So for example, in our system, we have a palliative care team that works together. So if someone is in the intensive care unit and then they go up to the hospital floor, and then they're discharged to the nursing home, and then they go to assisted living.
I think what we learned, though, is that communication, people have to communicate and they have to learn more. And we could use the internet for a lot of that and see what we can find out. I would like to thank our panel members for joining us today. Thank you guys for being here with us on Call the Doctor. Join us next week.